Good evening and welcome to Viewpoint. Tonight marks 14 days of lockdown for Gibraltar. Has it had an impact on suppressing COVID-19? Is the virus spreading in the health service? Have we done enough testing to know? Viewpoint speaks to the Director of Public Health, Dr. Sohail Bhatti.
Explain to teachers that there's an awful lot of evidence to indicate that children do very well with infection. I'm not saying everyone will be absolutely okay, but nearly all children do very well with infection, and you could almost regard them as super spreaders. So obviously teachers are concerned, am I going to get this virus? And I think the honest truth is you probably are going to get the virus. That in itself is nothing to particularly worry about. For the vast majority of people, it's not a serious disease. Over 90% of people are not even, 80% of people don't even know they've got the virus. So the first thing is, what does a mask do and how long will it be effective? As a PPE instrument, it is not very effective because it stops working after 15 minutes, and the latest research suggests that the virus stays on your mask for 9 hours. So if you don't take it off appropriately, you'll get yourself contaminated. Your best protection is washing your hands frequently and often. Wearing plastic aprons makes no sense. Wearing gloves just means you don't wash your hands, you touch surfaces, you touch your face, you get infected. So the most important thing, I think, is take sensible precautions, wash your hands frequently, don't be frightened, and generally love children because they are a blessing to the world. And the PPE, let not fear control what you wish to do and why you went into teaching, which is to look after children and give them an education.
Okay, what about in respect of people who might be concerned that in going shopping, for example, they might spread, they might themselves be asymptomatic, not coughing or sneezing, but actually be COVID positive, and they think that maybe wearing the mask might limit the chances of them spreading the disease?
What a great way of declaring to everyone you might be COVID positive and creating a sphere of avoidance around you. I don't think that works particularly well. I think the other thing to remember is that sunlight itself is a fantastic disinfectant, and that actually washing your hands and making sure that you always wash your hands frequently and often is the safest way. We know that the biggest risk is for people over the age of 70. Often these very vulnerable people have other conditions, and we've done whatever is possible to make that a good way to limit the risk. So I don't necessarily think that people walking in the streets need to wear masks. The way I see the way people use masks, they're actually showing a lot of their own internal anxiety and fear when they wear the mask. Wash your hands, it's a lot easier. Stop the cigarettes, it's probably more harmful. And don't let it rule your life.
Okay, so how many clinical diagnoses have been made to date via 111? Because of course when you talk about how many positive cases Gibraltar has, that's on the back of swabs. But how many people have effectively been diagnosed as having it by a GP via a phone consultation?
So the way it works is this: if you have a symptom, you will phone up 111. Now that symptom complex is very, very broad. We ask for things like loose motions, whether you've got a sniffly nose, whether you're sneezing, whether you've got a cough or a sore throat. We ask all those questions, and what happens is then a judgment is made whether you should be swabbed or not. And by and large, most people have been going. In fact, we've probably got too many people going at the moment because a lot of tests are coming back negative. So we constantly review our criteria, and people go to the drive-through and they get tested. Something like 76% of people that are going through the drive-through at the moment have been referred by 111. The other two are roughly evenly spread between A&E and GP referrals. So the system is, you have symptoms, you phone up the GP or 111, and by and large, if you meet some of the criteria, you'll get a swab. And we don't really have huge numbers of people who have active disease at the moment, which is why we're reporting a lot of negative tests, which I think is a good thing. However, there's still a lot of anxiety, and I think sometimes what we're doing is treating people's anxiety as if in some magic way the swab will tell them they're okay. I can't tell you the significance of a negative test. It might mean that someone's already had the virus or they've recovered from the virus. if you don't take it at the right time, you'll get a negative test. In fact, I'm told that the best time to take the test and get a positive result is day 3 of the symptoms, which is what we try to aim for.
Right, okay. But in terms of how many people potentially have COVID-19 in the community on the basis of clinical diagnoses?
So given that it's such a broad diagnosis and given that it's also hay fever season, at the moment we've got 301 people who are in self-isolation who are potential and possible COVID cases. We won't know if they're actual cases until we take the sample. We report regularly on the samples on a daily basis. You can see for yourself that the positive rates are quite low.
We saw an email that you sent to all staff, I think it was 10 days ago approximately, warning about the high risk of institutional spread, I think is the words used, in the GHA because of the number of healthcare workers who had it at that moment in time. Do we know to date what that figure is? How many healthcare workers have had COVID-19?
So roughly 25% of cases, pretty close to 25% of those that score positive at this moment in time have declared that they're from healthcare workers.
Those are swabs?
From the swabs, yes. These are positive swabs, but keep in mind that a significant proportion of healthcare workers in the hospital come from across the frontier. And there's an active epidemic going on in Spain, so there's a significant risk those people could have it and have brought it across the frontier and don't know, and we pick them up as positive cases. So it's not a reflection even on Gibraltar in many ways.
And what about people who are clinically diagnosed who haven't been swabbed yet? Do we know how many healthcare workers are off on that basis?
The figures, we don't separately collect that at the moment, but we're trying to put those systems in place. I'm sure your viewers will know that there's an awful lot of complexity and we're trying to work really, really hard to make this happen very quickly. But the best evidence I've got at the moment, there's roughly 98 of those that are self-isolating are actually members of staff and actually are in the ERS and care agencies. So that's a cumulative figure for all of them.
Could that become a problem in terms of absenteeism levels and meeting basic staffing levels?
I note that in England, because they have a much more prolonged policy of self-isolation and they self-isolate whole households, that something like 25% of doctors were self-isolating. And again, what I've done is tailor our self-isolation policies to 7 days for health workers and 10 days for non-frontline workers to enable us to get people back to work as soon as possible to keep our services going. So it isn't a significant policy problem. If we've got 100 odd people who are being in self-isolation, and that's for ERS and the care agency and the GHA, I think you're talking about almost a couple of thousand people there. So it's not a huge number in the big light of things.
Could you tell us on what basis your advice locally has differed to the UK in respect of home quarantines, noting that, for example, that Imperial paper that you referred to today suggests that it is one of the measures that might be taken to slow the spread?
So the issue for us is how slowly we can stop the spread or slow it down, this curve. And I say I've had to balance an awful lot of things, one of which is we're a small community and our essential services need to carry on whilst we're in this terrible position that we're in. Against that, I've got to try to make sure that we're protecting our community, and what I've always said consistently, the community that's most at risk are elderly, the people 70 and over, our senior citizens, if I put it that way. So if we can maintain our senior citizens safely, then I think I've taken a slightly more broader approach by restricting healthcare workers to 7 days self-isolation if they've got symptoms and 10 days for anyone that isn't a frontline worker. I haven't said that we should self-isolate people who are whole households, and I've not said that people who are in the vulnerable categories that are identified in England, such as pregnant women, such as people with asthma, people with diabetes, I just say that they have to follow standard winter processes. You normally take some precautions during winter. Just take those precautions. There are groups of people which are the extremely vulnerable, which Public Health England have publicised, and for them, I think it's best to follow the advice there of shielding as much as possible. If you've got an immunosuppressed condition, for example, probably safer for you to not mix in the same way that the advice is shown in Public Health England. So generally it's a nuance against the Public Health England advice based on where we are in Gibraltar, and the fact that I've been absolutely straightforward. We can't stop it. We can only slow it down, and actually for Gibraltar that would be a really positive thing, because it will mean at the end of this we will hopefully have the ability to trade much more widely than other countries who will have to remain locked down for, it sounds like it might be for a year, until the vaccine's produced.
So you think that Gibraltar the virus will have moved through Gibraltar sooner than that?
I would think it would, because we're a densely packed population and we can't sustain this level of lockdown for very long. So the issue for me is we don't get a situation where the whole hospital collapses because everybody falls ill at the same time. If we can manage that, we've still got lots of capacity in our beds. I'm not complacent about it, because it will fill up very, very rapidly once the peak, the spike happens. But if we can gradually let people have exposure and more of the population becomes immune to it, then the number of people that will actually then fall ill will be less. And the proportion, remember the proportions are roughly about 15% of people who get the virus may need hospital care. And if there are fewer people that need hospital care, then our hospitals will not be sort of overwhelmed, and that's what I'm trying to do. Your best bet if you do fall ill is a good functioning healthcare system, unlike what's happened in Madrid, what's happened in Lombardy and in Wuhan. Keep our healthcare function going, and that's what we're doing. We've expanded our hospital service by over 100%. We've expanded our ventilator service by 500%. That's a huge tribute to both the people of Gibraltar and the hard work that people in the GHA have put in to make this happen. And it must be acknowledged in the future that huge amounts of efforts have gone in to protect the people of Gibraltar.
You mentioned ventilators. In respect to ventilators, is there a sufficient number of qualified staff to maintain and use those?
So we did some special extra training. It was a short course that we arranged. I think it was 28 nurses went through a short course to work under the consultants that we have. I'm aware that there's even been someone from the military who's an ITU consultant that's been brought here. So I do think that we're doing the best we can, but the whole point about this very technical nature is you can't suddenly rustle people up out of thin air. So we're doing the best we can. A 3-day intensive course is enough and sufficient to be able to perhaps do the basics, and if you've got experienced staff in the background, then you can do some firefighting if that's what's needed. So the short answer is we don't have enough, but we're doing the best we can with what we have. In the same way people said we didn't have ventilators, just reminding ourselves we only had 5 ventilators at start, and now we're talking about 55.
Okay, we've moved away ever so slightly, Dr. Bhatti, but in respect of the 7-day period that you were talking about for healthcare workers, why is it that they have a quicker return to work than other workers?
I think you touched on the point yourself, Jonathan. You said, would we be able to keep a health service going if we had such levels of sickness absence? And I've titrated the risk of someone having continued to have the virus vis-a-vis the needs of the service. Remember, what's great for the service is to have a cohort of people that are immune. And so we asked for them to come back. The evidence seems to indicate that about day 8 the virus has almost completely disappeared, is about to disappear. In fact, there's some suggestion that the virus may persist, but it's no longer viable as an infectious agent. So we bring them back on day 8. For the others, day, waiting for 10 days is a reasonable compromise. In England, they wait 14 days.
And when they're coming back to work, the healthcare workers, are they being, international best practice suggests that they be swabbed because of the possibility of a false negative, that they be swabbed twice. Is that happening?
Not at the moment, but once I've got the new assay, we may well consider doing that, given that the biggest problem for us is we have to wait 3 days. So if we swabbed people and waited for the swab to come back, what difference would it make? It wouldn't make any practical difference, because then they'd be over the 10-day period anyway. So what we're doing is something that's pragmatic. But when I've got the new assay up and running, then we may well be able to do that there and then. It's a point of care test, and we'll be able to determine very quickly if someone needs isolating, someone's positive, vis-a-vis they're not.
So in short, it sounds like this new test, which is days away, which you said today Gibraltar was going to be able to implement sooner than the UK, is effectively a game changer for the way that Public Health Gibraltar approaches its testing.
It's a new weapon in our armoury against this virus, and it will significantly change the way that we address the black hole that we've had of knowledge. So yes, can you imagine, you come in with a sniffle and a cold, you've got a sore throat, is it the virus or not? We do the test, it says you haven't got the virus, therefore you can carry on with your life, you don't need to self-isolate, you can go back to work because we've assessed you at that time as being negative. Likewise, if you're positive, then we can provide the added support, send you home, make sure that you stay well, and phone you up regularly to see if you're okay. I think it will be a significant game changer in the way that we deal with it, yes.
Are there any associated agents, reagents that are required that might be an issue in terms of volume?
So we've managed to get the machines earlier than the UK has, and they arrived on Thursday, I think. The reagents are being prepared. Dr. Nick Cortez is actually part of the team that's developing those reagents, so he's best positioned to tell us when the reagents are available, and I've asked for tens of thousands of them actually, so I hope, and he hopes, that we'll be able to get them in about 10 days.
We had heard you talk about bringing in, being able to put in place in-house testing sooner, and we've had that deadline pushed back by a few days, twice now I think. What's the status of that?
So we're getting a specialist world-class microbiologist coming in from Public Health England. Dr. Catherine Ryan's due to fly in on Thursday to make sure that this assay gets set up. This is the standard assay they're using in labs all over the world, which actually, as I say, takes about 8 hours, but you really need to have that assay developed, and there are lots and lots of problems potentially that you want some expertise in. So I'm grateful for Public Health England for sending this expert. I hope that we'll have ironed out most of the problems by the time she leaves on Sunday.
Fantastic. Last thing to round off, if you would, the WHO has been saying test, test, test. What would you say to somebody in Gibraltar who thinks that we haven't tested enough?
I think that was perhaps a valid criticism when you'd only done 100 tests. We've done, I think, 12 times that volume in a matter of a few weeks, and that means we've done over 37,000 per million tests, which puts us near the top of any territory on earth. I'd like to do more. In fact, I've ordered tens of thousands more, and we'll do many, many more. But we've got to be sure that we're using them wisely, because we don't want to run out of these tests again, especially as it looks like the virus has been suppressed to some extent.
Internationally, such has been the destructive impact of this new virus that its spread is most often measured by two numbers: how many people are infected and how many have died. Thankfully, current data on this Tuesday evening suggests that nobody has yet died as a result of COVID-19 on the Rock, and long may that continue. But there are unavoidably question marks about how many people have been infected, because some carriers show no symptoms, and Gibraltar, like most countries, is not testing people who seem healthy. Dr. Bhatti has repeatedly said that the vast majority of us will need to get COVID-19 at some point. But if the rate of infection remains low, could it perversely make the spread too slow and the lockdown unsustainable on economic and mental health grounds? As the disruptive effects mount, there will be hard choices for Gibraltar's leaders to make. We'll continue to keep you up to date with the latest. And you keep doing what you're doing and look after yourselves. Good night.